Okay, we have 3 o'clock. I could have folks take their seats. Okay, I know I kind of went over the last couple of slides pretty quick, of post-traumatic stress disorder and OCD, so maybe I'll just take a few minutes and go back over that again, if that's okay, and then we'll move on to pharmacotherapies. Is that okay? Is that all right? Anybody? And we certainly, when we talk about the treatment on benzodiazepines, we'll connect with Dr. Emmett's presentation tomorrow. Okay, and as well as tomorrow. Oops. Okay, first thing about going back over, one thing we hadn't talked about, and I think it's pretty relevant, especially with the recent Supreme Court hearings, and that the ladies that came forward. Part of that, when we talk about and what they deal with, is PTSD. And what I think many people don't understand about PTSD in that context is that people don't forget. Now, a lot of the details may not be quite clear because under the different circumstances of something like that, whether drugs or alcohol are involved and all that kind of stuff. But it is still a distinct memory in this aspect that is ingrained. And that's why when you have a specific trauma of that type of magnitude, you remember this and your fear responses down to your amygdala gets really hardwired. Okay? So it's like anything else, like for example on a natural disaster, an IED explosion, all that, and associated also with traumatic brain injury, when you get that in critical care module, that really hardwires your brain to the point to where it becomes very difficult to treat. And so when we talk about that tomorrow morning with medications really only have, at best, a partial effect. A lot of these things like assaults cannot be treated with medication. And people, to go on with their lives, have to bury it deep under. But yet when an event is relived, this is when the amygdala and the locus coeruleus, hippocampus, prefrontal cortex all come back into play, reliving that event. Okay? So any questions on post-traumatic stress disorders and something like that? It could persist for years. Person just buries it deep inside. Okay? The thing about the OCD presentation is many people don't, it's a secretive type of presentation. It can be good sometimes, but mostly it's not so good. Some people, as part of their obsession, say about germs and dirt, they will clean their homes like at 3 o'clock in the morning, that kind of stuff. Okay? They know most of the original complaints sometimes are seen by non-psychiatrists. You saw the high degree of incidence with irritable bowel syndrome. So oftentimes they're seen by a primary care or a GI doc first. And they'll think it's that, but then they won't make that association to any particular psychiatric symptom. So it's very interesting where OCD folks will see a lot of non-psychiatrists. Okay? And again, keeping in mind, even as pharmacists, to be in our profession, we have to be a little OCD, right? If you're thinking about it, every prescription has to be accurate and correct. Literally, not one has to be wrong. Okay, that's why there's double and triple checking. So being a little OCD is okay. But when it impairs function to where, like I said, if you're a practicing pharmacist and you're checking a prescription, what if it takes you 20 minutes to check one prescription? You can't do that. You can't function as a pharmacist. So that's where it impairs function. Okay? So a little OCD-ness is okay. You need that. But it also depends upon where it impairs function. Okay? And again, time-consuming, it means it's more than 1 hour a day a person thinks about that. Okay? When we think about dirt. Anybody remember a fellow named Howie Mandel? Everybody see him on television? His is about what? He doesn't shake anybody's hands. If he shakes someone's hands, he'll be washing it like the next 6 hours, that kind of thing. Okay? Or he'll wear a glove and shake your hand, that kind of thing. Okay, so there are folks that obviously do have that problem. Repeated doubts about items, whether they've done them or not, like turning off the lights, that sort of thing. And everything, and they obsess, everything has to be done in a particular order. Okay? For example, persons with their closet and their clothes. Okay, anybody see the movie with Ben Affleck, The Accountant? Remember that movie? Anybody remember that movie? Well, he had autism spectrum disorder, but with OCD qualities. He would have his suits. He had the same gray suits, same ties. He just like had a dozen of them. But in his closet, they are all arranged exactly 1 inch apart. So when you look at a person's OCD closet, everything will be very compartmentalized, very organized, and measured to the inch of where they belong. And when it's out of sequence, they get really upset and they have to compulse and fix it. So that's the other side of obsession. They obsess about that sort of thing, and then they actually do it. Okay? Now, these folks will tell you that the obsessions are unreasonable. I know it doesn't make sense, but I have to do it anyway. That's unlike a person who's schizophrenic and psychotic, that God talks to me and I do this. Okay? So then that brings us to the compulsions, which is the repetitive behaviors that is in response to the obsession. So the hand washing is with dirt. Anybody remember a movie called As Good as It Gets with Jack Nicholson and Helen Hunt? I know you probably all these old movies. You probably say, where does he get all these old movies? Anybody see that movie? A long time ago. Well, that Jack Nicholson was a great OCD person, and he would wash his hands only one time with a bar of soap and then throw the bar of soap away. So he kept like 100 bars of soap in his house and had to restock it every day. So he'd wash his hands, throw the bar of soap away, and that's it. Wouldn't use the same bar of soap. So that was part of his OCD-ness. And eventually he trained his dog not to walk over cracks, that kind of thing. So those are things to think about. And again, the behavior is not pleasurable, but prevents a discomfort, okay? And they also recognize that the compulsion that they do is silly too. Well, I know I only used that bar of soap once, but, I just have to do it. Okay, understand that. So again, think about the compulsions in that realm, okay? Any questions about OCD-ness or post-traumatic stress in its presentation? Okay, so now we're going to start taking a treatment. So the first part, as I say part 1, we're going to deal with generalized anxiety disorders, panic disorders, and then social anxiety disorders. Okay. Mentioned, again, this is our, last session late in the afternoon. I can give you a break or go straight through and get done at 4:30. How many want break? Minority want break? You're the only one. Want me to do an eye-clicker question? Okay, so I'll go straight through. Is that all right? Okay. All right, again, it's your textbooks that are available. So here are particular learning objectives, and again, keeping in mind exam questions that will be based upon them. We're going to look at the treatment approaches and desired outcomes for the various anxiety disorders. Once we get past generalized anxiety disorders, all the other anxiety disorders will seem very similar in their treatment algorithms, and we'll point out some particulars with each of them. You should understand the kinetics of benzodiazepines and buspirone, because that's really the two drugs, well, one being a drug class being different today, that we'll talk about. Buspirone is in a class all by itself. As mentioned, there are different therapeutic algorithms for each of the different anxiety disorders. And then, of course, we'll look at the safety profiles of benzodiazepines, buspirones, And then we will also sprinkle in the antidepressants. The only new antidepressant we'll talk about tomorrow will be clomipramine. But certainly toward the end of today's class, we'll be looking back at the SSRIs and SNRIs as your first-line agents for the various anxiety disorders. We'll look at benzodiazepines in tolerance and withdrawal. That was part of its interest in safety originally, but then, of course, it comes with other problems with use. And tolerance and withdrawal are its main, I quote, Achilles heel. We'll look at the time and efficacy for duration of these agents for anxiety disorders, because keeping in mind with SSRIs and SNRIs for depression, it takes how long for effect? How many weeks? 6 to 8 weeks. We're going to see that with the data for the anxiety disorders, it takes longer. Interesting. So that's one of the first caveats. It takes longer. We'll show you how long. And of course, even though they do take longer, they're the first-line agents for a lot of different reasons compared to the benzodiazepines. So we've gone an evolution of benzodiazepines to antidepressants. And again, keeping in mind, it's really interesting that SSRIs and SNRIs, originally when they do get approved, FDA approved, and put on the market, it's really for depression. It was for these other aspects of cross symptoms with depression and anxiety that they looked at it for these particular indications. And then, of course, the market widely expanded. And then, of course, we really need to look at the drug-drug interactions, especially with benzodiazepines, antidepressants, and buspirone, because more often than not, that benzodiazepines are used with the antidepressants. And certainly that poses some other additional challenges. Okay, so a lot of folks now are doing generalized anxiety disorder screening. So this is a particular assessment. They call it part of the GAD 7-item questionnaire. And it's easy to use, that anybody can use it, okay? And you can see that it's scored 0 to 3, and 3 and 0 are easy to determine because it says nearly every day or not at all. Several days, it's kind of interesting, and then the other one is more than half the days. This is always taken on the context of what? A week. Okay, so when you talk to a person on a weekly basis, is it like 2 to 3 days a week versus more than 4 days a week? Okay, and then the last one means 7 days a week. Reason why I'm showing you this particular rating scale is that several companies that actually are starting with Walgreens as well as some others that are looking a 2-item GAD scale. So for example, if they are looking at number 1 and then maybe perhaps number 2, and if a person pings out a 2 or 3 in any one of those 2 items, that the pharmacist can make a referral to the primary care physician for that person to be evaluated, okay? Or, strangely enough, or interestingly enough, depending on your viewpoint, there are actually online cognitive behavioral therapy treatments that a person can sign up for. Ooh, think about that one. And so they can deal with perhaps anxiety. Now, I would say that's something you really shouldn't do, but that should be supervised at least by a psychologist. And then maybe the psychologist can also make a secondary referral to a psychiatrist or primary care doc. So what I'm saying is the bottom line is pharmacists are now becoming, depending on where you now work, are looking at being first-line screening agents for anxiety as well as even for depression. Okay? All right, so let's drill down with benzodiazepines. Okay?